So, Moni, have you heard about the band where everyone in the audience has syncope?
Oh, no. I feel like I know where this is going, and I'm not sure.
You don't want to guess?
In sync?
Oh, no. The Fallout Boys.
I can respect that.
Yeah?
I can respect that. Do they have any songs with the word fall in it? I don't think they do.
Not that I know of off the top of my head.
Sugar We're Going Down is kind of like falling.
Yeah.
Okay. All right. Enough of that.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
And welcome back to Curbsiders. I'm Dr. Moni Amin, and joined by my effervescent co-host, Dr. Meredith Trubit. How are you this afternoon?
Afternoon, evening, what is time when you've gone from the East Coast to the West Coast?
Yeah, that's right, people. We have flown to San Diego. We are recording this actually the day before the conference starts, but you'll be hearing this after our recap. Not that you really needed to know that, but here we are. Anyway, Meredith, will you please remind the good people in the audience what it is we do on this show?
Sure, Moni. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. And today, we have a fantastic conversation with our guest, Dr. Daniel Dressler. He's a professor of medicine, master clinician, director of internal medicine teaching services at Emory University Hospital. He's an associate program director for the J. Willis Hurst Internal Medicine Residency Program. He's also a Medical Student Society advisor and chair of the Medical Student Society's Leadership Council at Emory University School of Medicine in Atlanta. He's a textbook editor and deputy editor of any New England Journal of Medicine, Journal Watch General Medicine. He loves talking about syncope, but has never actually passed out himself. So without further ado, we can get to it.
Hey, Dan, thanks for coming on the show. We've been working on this one for a while, so we're excited that we finally get to record it. We're going to start with a few rapid fire questions. First, can you start by telling us a hobby or interest that you like outside of medicine?
Sure. Thanks for having me join. You're saying it took us a while because I'm a slow learner. Hobbies outside of medicine, I enjoy going to the gym. I enjoy running, hanging out with my partner Heather and our puppy Willa, and playing basketball a little bit poorly.
What's a little bit poorly mean?
Meaning I cannot shoot, but I like defense.
Okay. And you play with Heather?
I play with
Heather?
basketball. No,
Okay.
but
So you're telling
I'll
us,
just stop there.
so you're telling us you're more of a Ben Wallace, not a Steph Curry.
Yeah, I'm so far from Steph, but I will eat curry.
Okay. No lack of puns, guys. You've clearly accomplished a lot in your career. So what's some helpful advice either you've gotten or that you like to give to people that are seeking advice? Because I imagine people come to you a fair amount for that kind of thing.
Yeah, I had to think about this a little bit, although I think the best advice I got from one of my mentors early on, which I think comes probably from a former president or something like that, which is you can really accomplish anything that you want as long as you don't care who gets the credit. And, I try to keep that at the back of my mind for both things that I want to do and things that I think others can accomplish. Because many of us are always trying to get how do I get in the limelight? And it's okay to be outside the limelight and you'll be noticed.
That's a good one. I don't know that we've had that one when we've recorded.
No, I think that's definitely the first. And I think if you've ever worked on anything with anybody, you know that that's 100% true.
Yeah. I guess we can do one more question and then we'll go to picks of the week.
Sounds good.
Cool. Why don't we end on a fun kind of note? What's your a book, movie, show, album, any kind of art that you've been enjoying recently or not so recently?
I do spend a lot of time in medicine, but that's the question was outside of medicine. So I guess I was thinking of movies. did love Superbad and saw that at least somewhat recently on TV version. But what I watched recently with my kids was You Are So Not Invited to My Bat Mitzvah. And that was great.
That's the new Adam Sandler one. I haven't seen it yet.
Yeah.
Did you watch it?
No, because I was waiting to watch it with like around the same time you did.
Yeah.
Because I was going to have lots of questions.
Yeah. That's right. That's what I'm here for.
Hey, you did Never Have I Ever.
Mm-hmm.
Yeah. So you didn't have any questions. Anyway, we're getting sidetracked already. Picks of the week?
Yeah.
What'd you get?
Oh, man. So many because it's been a while.
It has been.
But a lot of mine are going to be a little bit kid themed.
I have no idea why.
So mine requires a backstory. So I recently bought my son, Max, a book. It's called The Paper Bag Princess. And it's really a tale of why women are great. But the funny part of this whole story is that I think I bought like a miniature version of the book. It's about 1 inch by 1 inch, but I didn't realize that. So when I got home, I had a whole like long set of like Zoolander references from my husband about how I was buying books for my child that won't read good.
Did Phil get the references?
He was the one giving them.
Oh, okay. I thought you said the other way around. Okay.
Mm-mm. So that was bringing me a lot of joy recently. And so that's going to be my first pick of the week while we're here in San Diego.
Yeah. And the size of it actually makes it seem a little longer.
Mhm.
I did get to read it recently, guys, if you're wondering. So mine, there's a couple. I guess we have several episodes, so maybe I can space it out. But I'll start with Dune 2, which I'm sure Paul Williams is judging me heavily for such a popular movie. But I have seen that movie 3 times in the theaters, each with a different screen. First time was a Dolby Cinema edition. Second time was in the 70 millimeter IMAX version. Highly recommend, although it's probably not available in that anymore. And then 2 days ago, when I didn't feel like packing, I watched it at the theater by my house. So Dune 2, highly recommend if you haven't already. It'll probably be on a streamer by the time this comes out. And I think that means we're ready to hop over to Cashlack to get to our first case. So I will take us there. So we have Tamara. She's a 42-year-old woman with well-controlled hypertension. She comes in for an urgent care visit with an episode of loss of consciousness. She was hosting an outdoor picnic fundraiser for her church and felt very stressed since the sound system was not working and the ice cream was melting before she could eat it. She had taken her lisinopril 40 milligrams, per usual, and hadn't hydrated much all day. She noted feeling nauseated, had some blurry vision, and then fainted while standing on the grass. Onlookers noted about 5 to 10 seconds of leg jerking before she came to and was reoriented. In urgent care, her blood pressure was 110/65, heart rate was 88, and her other vitals were unremarkable. No signs of trauma noted on exam. So before we get too far into what this might be, Dan, can we start with a few definitions? For starters, what is syncope?
Cool case. Yeah. So syncope, and I always start syncope talks with, well, how do we define this? Sometimes in the medical record, people list syncope, but they don't know actually what we mean by that. And so syncope is both loss of consciousness and postural tone. It happens suddenly, so it's not something that happens over hours or days. It is transient, so if you are passed out for like hours, days, or weeks, we call that, in essence, we call that coma. And the basic pathophysiology behind all types of syncope is that it is decreased blood flow to the brain, essentially decreased blood flow to the reticular activating system of the brain. And so things that are not doing that, we should not be listing as syncope. We might call it some other type of transient loss of consciousness. So if you lose consciousness because of low blood sugar, that is not syncope. If you lose consciousness because of a seizure, that is an electrical phenomenon in the brain. That is not syncope. And there are other etiologies that we don't call syncope, psychogenic things like that. So I think that's sort of where I like to get everyone at the baseline.
What about the definition for pre-syncope? Like, is that a thing?
It's a great question. So, pre-syncope is referred to as this, it's kind of interrelated with like vasovagal syncope or reflex syncope, where you feel like you're about to pass out. You may get this kind of prodrome, but you don't actually fully pass out because you either sit down or lay down, but pre-syncope, when there are at least 2 or 3 decent studies on pre-syncope that suggest that the risks related to pre-syncope can be similar to that of syncope. So while some people think, oh, those are completely different phenomenon, I consider them in the same genre.
Okay. So I guess that's a good segue into thinking about like the different causes of syncope. And so I think you sort of alluded to it a little bit, but like, can we kind of put it into the different categories that we think about for syncope?
Sure. Yeah. So 3 major categories. So we just talked about reflex syncope. And reflex syncope, the primary etiology is vasovagal episodes. And then within that, you also have like situational syncope, or things that predispose us to a vasovagal episode, or carotid sinus syncope, people who get recurrent episodes of essentially vasovagal syncope due to hyperstimulation of the carotid sinus. Then we also, our second major category is orthostatic syncope, which is predominantly volume depletion, but that can also be caused by medications, blood pressure medications, or other medications that reduce heart rate or blood pressure, and then autonomic dysfunction or autonomic failure. And that can also be medication induced, but in situations where that's not the case, we all know that there are predisposing factors to autonomic dysfunction, things like diabetes, things like primary neurologic disorders, as well as other things that are less commonly thought of, like HIV or rheumatologic diseases that can lead to autonomic dysfunction. And then finally, where we're all worried about syncope is with the cardiac causes. And so cardiac causes I try to break down into 2 major categories, which are you either have a rhythm problem, which I do on the dance floor as well, or you have a structural problem of the heart. And then with rhythm problems, there are really only 2 rhythm problems that can cause syncope. And when I ask the house staff about this, they look at me quizzically and then start throwing out names. And I just say, yeah, you're either fast or you're slow. Those are the 2 rhythm problems that can cause syncope. Any abnormal rhythm that can cause you to be heart rate to be fast or heart rate to be slow can lead to syncope. But we obviously think about things that are more dangerous, like ventricular tachycardia or torsades. We also think about dangerous slow rhythms like 3rd-degree AV block and stuff like that. Then, if we move to the structural causes of or structural cardiac causes of syncope, then those are really 4 major categories, which are valvular, which could be like aortic stenosis or mitral stenosis. You can have obstructive, which is generally like hypertrophic obstructive cardiomyopathy or HOCM. You can also think of atrial myxomas in that category. Pump failure is the third major kind of obstructive problem or, structural problem. And so pump failure can be either ischemic, if you have large ischemia to your left ventricle, or it could be a pressure overload phenomenon like cardiac tamponade. And then you have vascular problems that you can think about that could include like pulmonary embolism, but could include other less common vascular problems.
Yeah, I think it's a good breakdown of all the different causes, because I think if you just keep that framework in mind, it's a lot easier just to think through them because it feels a little bit less overwhelming. So, with the case that we have with Tamara, she comes in, and I think the thing that, especially when we're talking with learners, like it's really important to suss out certain things in the history. So what are the sort of history and exam things you're looking for when you're hearing a presentation from a resident or whatever you're thinking through too?
Yeah, great. So the way I'm thinking about this is because low risk things are really common, well, okay, I'm going to see way more low risk things than I am high risk things, but I'm always going to worry about the high risk things. So, but most of the low risk etiologies of syncope are diagnosed simply based on history. And so if I can get that really good history, then I can say, oh, I've made myself really comfortable that the patient has a low risk cause, either volume depletion or more commonly vasovagal episode. And so then we talk about, well, what actually causes the prodrome in a vasovagal episode? What causes those symptoms? And it's really a sympathetic surge followed by a parasympathetic surge. And so if you think about how all of us, when we stand up, your blood pressure drops just slightly, and that activates the carotid sinus. And when it does that, it then leads to the carotid sinus sending a signal to the brain. And that signal then sends back and says, oh, I need to increase the blood pressure a little bit, or I need to increase the heart rate a little bit. So what happens in individuals who develop a vasovagal episode is that they get kind of a hyperstimulation of that. So when they are standing up, the blood pressure drops, it sends a signal to the brain and says, I need a sympathetic surge. And so it gives that sympathetic surge, and that's what creates the first part of the prodrome, which is, oh, I feel anxious, I feel my heart racing, palpitations, and maybe I start sweating, maybe I get goosebumps, and that's the sympathetic surge. And so what's happening is then the blood pressure is jumping up a little too high, the heart rate's going up a little bit too much. And so then that activation of the carotid sinus then sends signal back to the brain saying, the blood pressure is too high, the heart rate's too high, and then it sends a parasympathetic surge. And that parasympathetic surge is, oh, I feel warm, I feel nauseous, maybe I vomit, and then pass out. And so those are the symptoms I'm trying to look for in the setting of a vasovagal episode or reflex syncope is, does someone exhibit a number of those symptoms of the prodrome such that I can say, oh, I'm pretty comfortable that was the prodrome that I'm looking for, and this was a vasovagal episode. That's on the history side. Other historical things and other physical exam things. So I would say some things can get a little confusing because we tend to think about, people talk about like incontinence and they say, oh, well, incontinence is more indicative of seizure, but that's not necessarily the case because there's about an equal frequency of urinary incontinence in patients who have seizure or patients who have syncope. And so it's really not a great distinguishing factor. And then other things, especially for early level learners or early level physicians or even early level attendings, if you haven't seen hundreds or even getting to close to thousands of cases of syncope, then it's sometimes helpful to have a risk scoring system that can help us decide, well, is this patient high risk or not? And there are a number of these scoring systems that have been out over the last few decades, but the one, and they each have like, we'll say, junky data behind them. It's not that they were studied poorly, it's just they're not as helpful. But we did get a new syncope rule that came out in around 2016, and that's the Canadian Syncope Risk Score, and that it was studied initially in about 4,000 patients, was validated in another 4,000 patients, and then was revalidated around the world in another 2,500 patients. And so we now have over 10,000 patients that have been prospectively studied, and so this is the largest cohort of prospectively studied that can help individuals, especially if you haven't seen a lot of syncope, to say, is this patient high risk, or are they moderate risk, or are they low risk, and can I potentially discharge them, or do I need to do more evaluation? But I'm speaking too much.
You're not. I'm just laughing because I feel like with syncope, that's always the question. To discharge or not to discharge is really where it like comes down to. And so I think that sums it up actually pretty nicely.
There were two things that I wanted to make sure we touched on. Especially in this case, she was jerking. Is that something, like, what do you think about jerking and or tongue biting?
Yeah, great. And so touching on the jerking, so there was a pretty well done study, and then these European or English, what's called the NICE guidelines that came out related to things that make us think about seizure in unwitnessed transient loss of consciousness. What would make you think about seizure rather than syncope? And so some of the things that make you think of seizure would be tongue biting, and especially lateral tongue biting. And so that probably has, if you're into evidence-based medicine and diagnoses, it has a likelihood ratio of close to 10, which is really good as a positive likelihood ratio to make you more suspicious of seizure rather than syncope. As a negative predictive value, it's not very good. So if someone doesn't have tongue biting, I don't like to say that rules out seizure per se. And again, these are unwitnessed episodes. The other things that can help you sort of increase your likelihood that seizure was happening rather than syncope are things like a postictal state. If it took you, 10 minutes or 20 minutes to come back to normal mental status, that's helpful. Patients who have benign episodes of syncope or even cardiac syncope, when they wake up, they're usually back to their normal mentation within a minute or so. And so those things are definitely helpful. And then, so the jerking issue is really important. So, and sometimes your observers of the passing out can't give you a great history, but there are some people who observe it. You can ask them, "Oh, well, show me what it looked like," and a lot of us know what tonic-clonic activity looks like. But the other key thing with jerking movements is how long did it last? So it is pretty unusual for tonic-clonic activity to last less than about 30 seconds. And so if you are described jerking movements in the order of a few seconds to even 5 or 10 seconds, well, that is almost never going to be tonic-clonic activity, which lasts 30 seconds to a few minutes. Obviously, if you get beyond a few minutes, that gets into status. And so patients with syncope, there's probably about a 10% incidence of myoclonic jerking that happens with syncope, just immediately post-syncope. And so a lot of times that is what observers have seen is myoclonic jerks. And then there's actually even a 1% incidence of what's called whole body stiffening, which is probably a transient hypoperfusion of the brain, lasts a split second. The patient comes back, they're totally normal neurologically when they wake up, and so it also means nothing. And so those things can be really helpful. I think the last thing I would say back to the Canadian Syncope Risk Score, just on a really quick note, is that those are available on apps. It's available on MedMath, or it's available on QXMD and so it's none of us need to memorize these things. You just pull up the app and plug it in.
Awesome. And we can link that in the show notes.
Yep.
So I guess now that we have like a better idea of what we're thinking about for Miss Tamara, what types of testing might you think about for her, kind of given her story?
Great question. So, yeah, I mean, her history is pretty classic for a vasovagal episode, or a combination of vasovagal plus volume depletion, meaning she was outside, it was hot, she probably wasn't drinking enough and got a little bit volume depleted, and then was also kind of not intentionally, but self-instigating sympathetic surges by anxiety and trying to get ready for this event. And so a lot of what she described sounds like a combination of vasovagal plus or minus volume depletion with that. And so then what kind of testing do I want to do in that situation? Well, the key is like, I want to do a good history and physical exam. As part of my physical exam, I'm always thinking of 3 main things to do. One is get vital signs, and then definitively get orthostatics and get them as early as you can. But there's no time point at which I say I'm never going to get orthostatics. There's no time point where I'd say, oh, we've gotten 2 or 3 liters of fluid, I might as well not get orthostatics. And that's because, well, someone could still be volume depleted even after that amount of time. And the other thing is with orthostatics, you can sometimes diagnose autonomic dysfunction by seeing a drop in blood pressure where the heart rate stays stone cold the same. And so when you see that, that is highly suspicious for autonomic dysfunction. And so I'm always wanting to see orthostatics done. And when you look at studies that have been done on this, we still only see less than half of people who are admitted to the hospital with a syncopal episode that's documented that get orthostatics done. And so we're kind of trying to pound that in. Then the other exam findings that you're looking for is you want to do a good cardiac exam and a good neurologic examination. And we're talking to practicing clinicians, so I think everyone knows and understands what is meant by good, complete, and documented in a complete fashion. The other piece with studies is, well, I think every guideline is recommending that every patient with a syncopal episode gets an EKG. Even if you're so highly suspicious that this is a vasovagal episode, an EKG is relatively inexpensive, and you don't want to miss congenital reasons to have a syncopal episode, especially in a young person, but like hypertrophic obstructive cardiomyopathy, and that incidence can actually increase as you age. But there's also congenital prolonged QT syndrome. There are other rhythm problems, or even RV dysplasia that could lead to syncopal episodes or arrhythmias, and so you just don't want to miss that, and it's relatively inexpensive. Short of that, there are no other definitive, oh, we have to get this or that test. There are no blood tests that you necessarily have to get, and some of that should be based on your level of suspicion. So if you are a person seeing this patient in your office, you might say, oh, I clearly, based on history, diagnosed a vasovagal episode. Your exam is normal, your EKG is normal, and so that may be the extent that you need to do. I don't need to put you through a battery of tests necessarily.
Okay. So with that in mind, how confident in your vasovagal history are you? Because I feel like often what I get from maybe the emergency room is calling him, the story sounds very vasovagal, but this person might have an extensive cardiac history that then plays into it. So
Yeah, I think you bring up great points. Is that so? As internists and definitely as hospitalists, we rarely are seeing a patient that has 0 or 1 or 2 problems. And so we definitively want to look at those, their prior history and see, well, how is that playing in to our decision making? And so what is going to make me concerned, what is going to make me think about my patient more or decide, oh, I may want to do more testing is, do they have other cardiac diseases? And this plays into partly the Canadian Syncope risk score, ferreted some of that out, where any patient that has any type of cardiac disease, whether it's coronary disease or a prior history of a rhythm problem, including AFib, or a prior history of cardiac dysfunction like heart failure or coronary disease, all of those patients get extra points for having that history, and that contributes to why you might think someone might be a higher risk. That history in and of itself, if that's the only thing, may not contribute enough to say, oh, I'm worried about a patient. But I'm like you, like if the patient is called to me about like, oh, I want to admit this patient, then I might consider that and say, oh, well, I may go through the Canadian Syncope risk score and say, oh, well, I calculated everything out and this patient is low risk, and so I feel comfortable doing an outpatient workup. Or I might say, oh, well, they're hitting moderate risk. Or if my ED doc is still really concerned, despite, having this discussion, it's easy enough for me to admit the patient that you usually already have some labs. It's easy to have them on telemetry for 24 hours and see a set of cardiac enzymes. And even though I wouldn't don't always necessarily do that for all of my patients. There may be situations where that, is reasonable.
Yeah, so we've covered the cardiac history, and now I want to talk about the elephant in the room, PEs. So D-dimers, and then sort of going through the PESIT trial in terms of how we think through that.
Yeah, so the PESIT trial, which also was published back in 2016, really interesting study in that it was kind of the first trial that looked at a cohort of all individuals who are coming into emergency rooms, syncope. Now, the caveat to that is they did exclude patients who this was not their first episode of syncope. Why is that important? Well, actually, first episode of syncope portends a little bit higher risk for patients. And why is that? Well, in part because you have a number of patients who, when they have multiple episodes of syncope, they just have recurrent vasovagal episodes, which are relatively benign, but they come in a lot. There are also patients who have psychogenic etiologies of syncope, also tend to have multiple episodes. And so the PESIT trial looked at first episode of syncope, and then what did they do? Well, they did a very structured workup of these patients in the emergency department, meaning a really good history, a structured history and physical exam. They all got EKGs, and they got some really basic lab studies, and then they decided who could be discharged because they had a low risk of a low risk etiology of their syncope, like they had vasovagal, or it was drug induced, or it was volume depletion. And that was actually about 75% of the patients. And so then they only admitted about 25% of the patients. I don't know about you guys, but my hospital, at least anecdotally, seems to admit more patients than 25% of syncope. Now, I say that a little tongue-in-cheek because I'm not down there in the emergency department seeing all the patients that they may be discharging. However, there is actually some data related to patients who come into hospitals with syncope coming into the U.S. versus coming into Canada, for example, where the patients coming to the U.S. emergency departments with syncope, close to 80% of them were being admitted, versus patients coming into hospitals in Canada, somewhere between 15 and 25% of them were being admitted. And so I mostly bring that up because the PESIT trial has been criticized based on some of the findings that we'll get into about what it's saying, the percentage of patients who might have a PE when they come in with syncope. But part of that is because they did exclude and essentially discharged home a lot of their patients who were low risk. And so then the only patients that they were admitting were reasonably higher risk. And they were first episode of syncope that made also them a little bit even higher risk. So with the PESIT trial, those patients came in, and the final results were about 4% of all the patients that came into the ED had a PE. And the big result of the trial was that, 17% of admitted patients with syncope have a PE. Well, many of us say, well, we don't really see that, but it's in part because we're admitting a lot more low-risk patients in our hospitals. Circling back though, so what did PESIT do? So those patients that got admitted, what did they do with those patients? Well, they said, these are all high-risk patients and we don't have a low-risk etiology, and we didn't also clearly diagnose some high-risk etiology like you had a malignant arrhythmia or something like that. And so then all of those patients, they said, well, they're high enough risk where we're admitting them and we don't know what the etiology is. And so we are going to get a simplified Wells score and a D-dimer on each of those patients. And so then they did that, and if your D-dimer was negative, which was about 2/3 of those admitted patients, they did nothing further to work up for PE. If your D-dimer was positive or your simplified Wells score was positive, then they said, well, you're high enough risk, and so we're going to do imaging for PE. And then they found a relatively large percentage of patients who were admitted, who were high risk, admitted for syncope, who had a PE. How I am using this myself and how I'm asking my trainees to use this is understanding that we are seeing more low risk patients admitted to us. And so what I want my residents to do, what I want my hospitalists to do, what I want to do is then redo my own workup of the patient. If I work up the patient, I say, oh, there's clearly your volume depleted, or clearly you have autonomic dysfunction, or you definitely had a vasovagal episode. And my ER docs who are crazy busy and seeing way too many patients, they may just not have had time to do all of the things that I may have more time to do. And so if I made a low risk diagnosis when I saw the patient, then what am I going to do? I'm just going to discharge the patient. It's only when I've admitted the patient, I don't think that they have a low risk diagnosis, or not one that I can say is clearly evident. And I did not diagnose some other high risk diagnosis, and I just don't know what's going on. Well, then I am calculating a simplified well score, which takes a few seconds, and then I am ordering a D-dimer. And if the D-dimer is positive, then I will get a imaging study. I find that this does not, has only maybe increased my number of imaging studies in a year by like 5 or 10%. But I now do think about it a little bit more because the risk is a little bit higher. There are a handful of studies that were not as high quality as the PESIT trial. A number of retrospective studies followed the PESIT trial because people said, oh, they didn't believe those results. And there were 3 or 4 retrospective cohort studies, or combinations of multiple retrospective cohorts, that said, oh, this is not true. But those studies don't well define syncope. Those studies include a lot of patients that may not even have syncope. Some of those studies actually include outpatients rather than ED patients. And then there was one follow-up study to the PESIT trial that came out in 2019 that essentially did a similar algorithm where the patients did get the same kind of algorithm of the D-dimer and the Wells score if the patients were high risk admitted. And they found somewhat similar results. They found that about 2.5% of patients coming in the ED did have a PE, which is again higher than some of these other studies were showing, which around 10 or 11% were of the admitted patients who got imaged did have a PE. So it was somewhat similar results to PESIT. And so that's why I'm still following this algorithm to still get the D-dimer on occasion when I admit patients. And even if I look at experts in VTE and what are they doing and what do they recommend if patients come in with syncope and they don't have a clear low risk diagnosis, and especially if it's their first episode of syncope and they're getting admitted, hey, probably would get a D-dimer and make sure that they're not having a PE.
In those that they do find a PE in, like if I'm thinking about syncope and PE, I think of like massive PEs or like submassive. But I often feel like when I do a syncope workup and get like dimers like elevated, get the CT, I get these like segmental PEs. And I'm just curious if that really can explain that patient's syncope from like a pathophys standpoint.
Yeah, no, it's another great point and question I get all the time. So interestingly, in PESIT and in some of these other trials, when they studied patients, meaning they imaged them, if they had a positive D-dimer or positive Wells score, about 2/3 of them actually had large PEs, meaning it was either a saddle embolus or a lobar PE, but 1/3 had a segmental or subsegmental PEs. Like the question you ask is, well, how could that cause someone to pass out? there are individuals who, at least on a theoretical side, have thought about this, and I don't think I at least haven't seen someone studied it well, but there's a thought that PE and the potential inflammation related to that can activate receptors within the lung that then could lead to vasovagal episodes. And so that is thought that why we might be seeing some of these smaller PEs and someone passing out where it's not necessarily a complete vascular obstruction that's doing it, but it was like the symptom that led us to like lead to even consider that or look for it.
Okay. We've done a lot, so I'm going to maybe summarize a little bit about what we've done so far, and then we can advance the case. So for Miss Tamara, at least, it sounds like she comes in, has a very classic like vasovagal story, but would probably still like do a Canadian syncope risk assessment to really evaluate low risk, high risk based on like the other history you're getting, based on her EKG. And then because kind of her other history and everything really pointed to vasovagal, kind of limiting the further testing that is like necessary for her. I think the only other question that just we can kind of quickly go over, which I think you may have alluded to, was so in the patients that come in, with their jerking movements or I guess even like the lateral tongue biting, CT, EEG still, or if they give you a good like other history for their syncope, can you kind of bypass that?
Yeah, I've been reading about, and I got very interested in syncope in residency because I felt like every time I was working on a different team and a different attending, the workup seemed to be different and made no sense to me. And that's why I started like reading about it and like trying to figure out the evidence and the data behind it. And this comes to like one of the early times when I was running a conference, and I spoke about syncope. I had this guy came up to me at the end and said, "You say all that, but that's a bunch of BS because I'm going to get sued if I don't do the CAT scan or the EEG." And so I tried to look into this more and tried to help. And we had a rather avid discussion about this. And he was just like giving it to me. And he was like easily 10 or 15 years my senior or what have you. But I feel like I was able to like at least get some things across. And I do this based on data now. And so for our particular patient, and I'll get into the data, but for our particular patient, Tamara, because her jerking was short in duration, only a handful of seconds, did not get to like 30 seconds. It was not described as tonic-clonic by the observers or when we asked them as clinicians and about that. And she came to pretty quickly, so she did not have a postictal state and she didn't have any tongue biting. So we didn't get any other things that to suggest seizure. And so the jerking movements alone are not going to prompt me to get the brain imaging or the EEG. And that is now both supported, again, by mostly retrospective cohort data, but it is supported by that data. But it's also supported by organizations. So like I believe SHM has something on this as well, but American College of Physicians does, the American Academy of Neurology, as well as the American Academy of Emergency Physicians. All of these organizations recommend do not do imaging in patients with simple syncope unless you have neurologic findings based on history or physical exam. So in a few jerks does not meet that criteria. And so I think we can feel comfortable, and I will say that that gentleman who came up to me that first conference, which was probably a couple of decades ago, is one of the few people that has come back to my conference every year for the last 15 years.
Eager to learn something new.
Does he come up to you every year and
Oh,
have
yeah.
a conversation?
He comes up to me every year and we have a conversation. I probably remember this conversation well better than he does, but we don't talk about syncope anymore.
All right. So for Tamara, just like we were kind of talking about, her physical exam, labs, unremarkable. We did orthostatics, but after she had been hydrated, so they were normal. And ultimately, at this point, she's ready to go home. She's anxious about what happened. How might you counsel her on, what transpired and what to be on the lookout for in the future?
Yeah, that's great. So definitively one of the most important things is helping patients feel comfortable going home and what happened here. And so I generally describe what happened for this patient as a simple faint. And that is sort of like the layperson or colloquial terminology is you had a simple faint. And I also tell them that this portends no increased risk for you as compared to anyone who's never fainted. And so that usually helps people feel more comfortable, and then we just go over basic counseling like, oh, if you're going to be outside in the heat for long periods of time, hydrate yourself well. There actually have been studies on, especially on people who know that they're at risk of having vasovagal episodes, if they know what those prompting factors can be, like giving blood or things like that, then if you do something very simple like drink a full glass of water right before you do it, that's been shown in some reasonable studies to reduce the risk of developing vasovagal episodes. But it's very basic counseling that you had nothing that was high risk.
I imagine since it's low risk and a simple faint, you probably don't maybe recommend urgent follow-up for someone like her?
No, as long as I think almost anyone who comes to an emergency department, I say, yeah, you should get to see your primary care physician within the next few weeks. Let them know what happened. I send them information about what happened and what we think happened. But this does not require any urgent follow-up. We already did the good history physical exam, got an EKG, and we feel comfortable. And so we can help the patient feel comfortable.
I'm realizing as we're ending this that tomorrow could have been me with her audio anxiety.
Yeah, I'm also thinking of all the times I passed out in the OR as a medical student. And I just want to say, if I had known I just had to drink a big glass of water before that would have been helpful.
Did you lock your knees?
I did lots of things, probably wrong.
Okay, I think we probably need to get to the next case.
Sounds good. All right. So the next one is we have Travis. He's a 62-year-old accountant with a past medical history of hypertension, hyperlipidemia, with mediocre control on his lisinopril, HCTZ, and atorvastatin. He's been stressed at work due to upcoming deadlines. 'Tis the season. And he noted a few seconds of fluttering in his chest, a sudden loss of consciousness. He came to and found coworkers standing over him, paramedics on their way. And then when he got to the ER, he felt a little tired, no chest pain, shortness of breath, palpitations, or any other symptoms. Vitals were unremarkable, and exam and basic labs were also unremarkable, including a troponin and a dimer that they did in the ER. His EKG showed signs of right axis deviation with a QRS axis at 110 in duration of 140 milliseconds and overlapping QRS complexes from deep precordial S waves. He's eager to leave, though, and get back to work to get up to all those deadlines. So this seems a little bit different than the last case we just talked about. So are there other tools you're using, or are you still using your Canadian Syncope risk assessment?
Yeah, no, clearly this gentleman is a little bit more concerning for a couple of reasons, but I still would encourage someone to use the Canadian Syncope risk score for this patient, and it would likely be helpful, and we can get to that in a second. But what I would say, what makes this patient concerning? Well, he had what I would call palpitations, and meaning he had this fluttering, he felt this fluttering in his chest. Palpitations is a challenging symptom because it can happen simply with vasovagal or reflex syncope, but it also can happen with arrhythmias. And so you want to take it seriously. The other concerning thing for him was, aside from the palpitations, he kind of lacked a prodrome. So there was nothing else to suggest a sympathetic surge and a parasympathetic surge. He just felt this fluttering and then he passed out. And so that makes me worried that could there have been some sort of malignant arrhythmia. But let's say we didn't know some of that, or as an early level learner, I wasn't sure, I could still plug his information into the Canadian Syncope risk score. And doing that, even though he doesn't have a lot of past medical history that would contribute to it, what does contribute is some of his EKG findings. And so the fact that he has a abnormal axis, either a leftward or a rightward axis, and that he's got a prolonged QRS duration, those are two concerning findings, and those both would contribute to higher risk based on the Canadian Syncope risk score. And so when I say higher risk, well, what if we put those in? If we put those into Canadian Syncope risk, we'll pretend like we're doing it now, and we end up with a risk somewhere between 5 and 13%. Why is that? Why is it that variable? At the end of the Canadian Syncope risk score, there's a judgment call, and the judgment call is, do you think that the patient had a vasovagal episode? Do you think that the patient had a cardiac cause of their syncope? Those are the two options. Or do you think you're not sure, or neither? And so clearly, looking at this patient, I would not say that, oh, I can clearly diagnose a vasovagal episode, and so I'm not going to make that judgment call there. You can make a decision of, well, do I think I'm just not sure, or do I think it's definitively cardiac? You could say one way or another. If I'm not sure and I say, well, I'm not going to call it cardiac, then it would be about a 5% risk, which puts a patient at moderate level risk. Moderate being anywhere above about 2 to 3% puts you at moderate risk. And then if you said, oh, well, I do think this was cardiac because there was no prodrome and he just had this palpitations and then passed out, then that would put you at about 13% risk, which is definitely too high to just discharge a patient. And so the Canadian Syncope risk score will help anyone in that situation, if that got enough to what you were trying to get me to talk about.
I think so.
So based on Travis' history and what you just said, it seems like you want to keep him. And so I guess the next sort of big hurdle to cross is the one about further cardiac testing, echo or anything else that you'd be thinking about. Because I know echoes are in the controversial range sometimes.
Yeah, other great points. Echo, sort of thinking, well, when would I get an echo in a patient with syncope? These used to be kind of done ubiquitously based on some earlier guidelines back in the mid 2000s that suggested, well, anyone who has a syncopal episode and you don't know what's going on, you should get an echo. And so we got way more echoes. That guideline, obviously, or I don't know if it's obvious or not, but was coming from a cardiac society. So it was maybe a little bit self-serving, although not necessarily intentionally so. But echoes are pretty dang expensive. I mean, it costs, in my system, probably costs $1,500 to $2,000 for an echo. And so I don't want to just get those kind of willy-nilly on everyone. And so who do I get echoes on? Well, the newer guidelines recommend getting echoes, and this is based on data. There was actually a things we do for no reason, which is getting echocardiograms for all patients who come in with syncope. And so that publication kind of documented there's about 6 studies, all retrospective cohorts, but showing that if we get echoes on everyone with syncope, the yield is only going to be 1% or less. And so then who do we get echoes on? Well, echoes should be based on if you have either history findings, which there's not a lot of history findings that say I should get an echo, but one of the big history findings would be if you have exertional syncope, if you pass out while you're exerting yourself, that's a high risk for an obstructive phenomenon, and so you'd want to get an echo related to that. But mostly physical exam and EKG. So physical exam, if you hear a new murmur in a patient who had syncope, well, hey, that's reason enough to get an echocardiogram or abnormal EKG. So when EKG is abnormal, and there was actually a good recent study in 2019 that kind of defined these abnormalities on EKG and then defined echo abnormalities and could these be predictive? And so it was somewhere on the order of if you had no EKG abnormalities, your risk was about 1 or 2% of having an abnormal echo versus if you had any abnormality on EKG, and those abnormalities defined as like abnormal axis or abnormal QRS and a few other things, then you had about a 25% chance of having an abnormality on your echo that could explain the syncope. And so echo is something that is a useful tool, but just not something that needs to be done in everyone. And so do we want to talk about other tests or should I?
If you have other tests, go for it.
Yeah, I mean, so definitively in this patient, who has a widened QRS, not unreasonable to get an echo. To me, I'm not sure it's going to really even matter what the echo findings show. With the widened QRS, I am probably going to get my cardiologist involved because I'm concerned that the patient may need an EP study or electrophysiologic study. And why is that? There was another good study, and sorry, I don't remember authors and names of the study, but I can give you any of these references if you want any of them. But there was a study done maybe 10-ish years ago that looked at patients who were coming in with syncope who had a widened QRS, I think over 130. And so what did they do? Well, they said, well, do we have a diagnosis based on the EKG or telemetry when they in the ER or in the hospital? And that was only about a third of patients got a diagnosis. And so what did they do? Well, they actually did EP studies on everyone. And so once they did an EP study on everyone, they were actually another third of the patients, just based on the EP study, were able to get a diagnosis that was a rhythm problem diagnosis. Most of them were actually slow rhythms like inducing, like third degree AV block or things like that. And then a smaller proportion did have like inducible malignant arrhythmias, like a VT or something like that. So then we had 2/3 of them diagnosed based on that. The rest of the patients, if they didn't have a diagnosis based on that, then they got an implantable loop monitor, and another sixth, so about 17% of patients additionally got diagnosed. So if they followed that algorithm in patients with a widened QRS, then they were able to get diagnoses in close to 90% of the patients. And these are not like benign diagnoses. And so, if I see a widened QRS, I'm going to have a very low threshold to get a cardiologist involved or maybe an electrophysiologist involved to help make some of this decisions and or say we need to go to an additional testing that only they can really do.
So I have this memory from training of one patient I had who came in as syncope. It sounded like cardiac syncope, like she had injuries from her events and everything. But the initial workup was negative. Long story short, when we were about to discharge her because we hadn't found anything, she syncopized again, and it was like a VT run she had on her monitor.
Yeah.
And then one thing led to another, and it turned out she had like a big LAD lesion. So one of my questions I often have is like, are there anything that would indicate going down like an ACS pathway for their arrhythmias? Or you're getting like your cardiologist involved anyway, so it's kind of irrelevant for
Well, no,
you,
it's a great point because, I mean, ischemia can lead to syncope. And so while the overall yield of our patients admitted to the hospital who we stick on telemetry and we might get cardiac enzymes, I say might, but like I'm seeing like every patient getting at least 1 or 2 sets of cardiac enzymes. That yield is relatively low, but some patients do have that as the etiology. So anyone who says they had any sort of chest pain either before, during, or after their syncope, I'm going to consider them or have a much lower threshold to do cardiac workup, even in addition to, even if my troponins are negative, I might do a stress test on them. And that is because you can have, we definitely see unstable angina and left main lesion or an LAD lesion. Those are the lesions that could be large enough that even in a transient ischemic episode could hit enough of the left ventricle to cause it to, even if transient, to stop for a few seconds, could cause you to pass out. And so I think it's definitely important to think about and potentially pursue while you've got the patient kind of quote unquote captured in the inpatient setting. Yeah, which also brings to mind, like, well, we got to use our gestalt, and do we have a level of comfort that this was something low risk? And again, that goes back to the history that we talked about before. And what makes all of us uncomfortable is when we don't clearly have something low risk, we don't clearly have something high risk, and we're in this intermediate, and then do I keep you in the hospital and do a bunch of things, or do I let you go home and try to schedule some things in the outpatient, or do I let you go home and do nothing? And it always makes us all feel a little bit angst provoking.
Yeah. So hearing that story, Meredith, I think everyone should go home on a Holter, oh no, a loop recorder, the longest one. I can never keep them straight. So that's probably a good place for you to kind of walk through the different monitors and like what we should be, like when to order what, because otherwise I'm just going to send everyone on like the 2-year monitor. So
yeah, and I will say, syncope I find very challenging to, and it gives us all a little bit of angst. And so, but I do see some practitioners, or I've even had family members say, "Oh, I passed out, and my doctor gave me this monitor to," and I was like, "Oh, have you ever passed out? Like, how? What's?" And so, what do I do with loop monitors? So I kind of separate them into 3 or 4 different types of monitoring. So you've got a Holter monitor, which is actually recording your entire rhythm for 24 or 48 hours, however long you order it for. And then there's a clinician who is then looking at that entire thing and saying, did they find any rhythm issues? Then you've got the different types of loop recorders, an external loop recorder that's kind of sticks on your skin and can stay there for up to a month, maybe 2 months. A lot of people don't tolerate it hanging out there, or just they get sweaty and it comes off, or they have body hair and it won't stay on. And so, but theoretically, you could have those for a month or so. And then you've got implantable loop monitors, which used to be more invasive than they are now. These days, it's a little device that can get implanted like right under the skin and can also be easily taken out. And those can stay in for months to years. And those are not continuously recording a rhythm, but they can, they're like recording and erasing, and they can identify abnormal rhythms. So who should get these monitors? Usually it is not the person who's coming in with a first episode of syncope, unless I have something to suggest that there's a high risk of an arrhythmia, meaning they complain, they have palpitations is their main symptom, and then they had palpitations and they passed out. But the challenge with any of these rhythm monitoring things is like, well, if you come in with a first episode of syncope, you didn't clearly have something that was suggesting a rhythm problem, or that you had palpitations. And then, so when's the next one going to happen? Maybe never. Actually, the vast majority of people, it'll be never. And so usually when I'm considering ordering these things, is either they have palpitations as a predominant symptom, and maybe they've had them even though they haven't always passed out with them, or they've come in multiple times now. So now if they've come in 2 or 3 times, and I know, well, they came in a month ago, and then they came in now, well, okay, I know I can guesstimate that the next one may happen around that same time frame, so I can say, oh, I could consider a loop monitor because I can put that on for a month or so, meaning an external loop monitor, versus like, oh, someone who says, oh yeah, I've passed out 4 times in my life, and they don't give you really clear that these are vasovagal, and the 4 times in their life was once 12 years ago, once 8 years ago, once a year and a half ago, and then once now. And so now these episodes are occurring relatively infrequently, and I know a Holter won't catch it. I'm pretty sure a external loop monitor won't catch it, and so that's an opportunity to say I can request an internal loop monitor. So that's how I'm thinking about those different types of monitoring systems and whether or not I'm going to use it. But I'm generally not, for the vast majority of patients, recommending that they get it on a first episode of syncope, because it's if I did that with everyone, those are reasonably expensive, and the yield is going to be relatively low.
We have covered an impressive amount of stuff. Would you agree, Meredith?
Yes.
So maybe a couple take-home points, 2 or 3 take-home points for
Sure.
us?
My main take-home points is always do a good history that is looking for those prodromal symptoms that we talked about. Doing a really good physical exam, always doing orthostatics, always doing a good and complete cardiac exam that realize we all don't always check the JVP, don't always check the apical impulse on every patient, but in my patients with syncope, I'm going to be intentional about doing those things, and then doing a really good neurologic exam as part of that physical exam. Again, something that feels like, well, do I really need, the patient seems kind of normal in front of me, but I don't want to miss things. Can say that there's been once or twice where a cerebellar ischemic episode was not can be missed because I didn't do a good cerebellar exam as part of my neurologic physical exams. So good history, good physical exam, and then the other key take-homes, if there's no clear low risk or clear high risk etiology on initial evaluation, then I would do a simplified well score plus a D-dimer. If either of those are positive, I do image my patients to rule them out for PE. And then only do neurologic testing for patients with history or physical exam findings that suggest a neurologic etiology, either seizure or stroke, and then echo for suspected structural heart disease, and we talked about that.
Sweet. Do you have anything to plug for yourself?
Probably my nose with all of my allergies. But I guess I would say if you're looking for a guideline on syncope, the ACC/AHA guidelines are a little bit challenging to read and follow. The European Cardiology Society has a very easy to follow and very easy to read, and everything they write makes a lot of sense. And so I tend to go to that. They are very long guidelines, and so, but if you're looking for something, what do I do about tilt table testing? And then I can go there and they explain it very simply.
Great.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Get your show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. Plus, twice each month, you'll get our Curbsiders Digest, recapping the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value practice-changing knowledge. And to do that, we need your feedback. So please subscribe, rate, and review the show on Apple Podcasts or Spotify, or email us at askcurbsiders@gmail.com. A very special thanks to our writer and producer of this episode, Dr. Emi Okamoto, and to our whole team. The Curbsiders is produced and edited by the team at Podpaste. Elizabeth Proto runs our social media, and Stuart Brigham composed our theme music. Until next time, I've been Moni Amin.
And as always, I'm Meredith Trubit. Thank you and good night.